everybody. My name is Esteva, and I'm going to be teaching you today about transcultural nursing. Today we're at St. Joseph Mercy Hospital in Ann Arbor. Today is Wednesday the 25th, so thank you all. We're going to be learning about transcultural nursing. So the objectives for this lesson are to learn what transcultural nursing is, learn how to provide culturally congruent care, and learn some of the terms associated with transcultural nursing. So what is transcultural nursing? The definition is literally a formal area of humanistic and scientific knowledge that practices focused on holistic care, phenomena, and competence to assist individuals or groups to maintain and regain their health and well-being, and to deal with their disabilities, dying, or other human beneficial ways. So again, a big long definition, but what it really means is a scientific method that has shown us that individuals from different cultures all have similarities, and we want to provide culturally congruent care to be able to promote their well-being, not just medically, but in every pathway of their life. So historical development. It was first conceived in the 1950s by Dr. Leininger, and field research actually started in the 1960s in New Guinea. In 1973, the Transcultural Nursing Society was established, and in 1978, the first publication of transcultural nursing was published. So theory development. The theory is called culture care. So the subjectively and objectively learned and transmitted values, beliefs, and pattern life ways that assist, support, and facilitate or enable another individual or group to maintain their well-being, health, and to improve their human condition and life way in a way to deal with illness, handicap, or death. So the purpose is to discover, document, interpret, and explain the predicted and multiple factors influencing and explaining care from a holistic practice. So it's examining every single culture and trying to find what makes that culture unique and also similar to other cultures, and providing care that will help them deal with any sort of illness or that comes up. So the basic constructs, the theory of culture, care, diversity, and universality. So obviously some things are different between cultures, but what this theory found is that there's quite a lot of similarities between cultures. The second basic construct is emic versus etic care. Emic care is lay people care, so I like to like home remedies or any sort of that, things passed down from generation to generation, like wives' fixes and that kind of thing. Etic care is professional care given by professionals, usually taught in a university. Culturally congruent care is care based on the knowledge, acts, and decisions using sensitive and knowledgeable ways to appropriately and meaningfully fit the cultural views, beliefs, and life ways of a client. So learning what that client needs and providing the care in that manner. The other construct is care diversity, which is differences and variabilities from culture to culture. Care universalities are the similarities between the cultures. Environmental context is the totality of event or situation that happens within that culture. So the example that I like to give in the 1920s in the U.S. was the Great Depression. So when you have patients who were raised in that era, they tend to save everything, like empty tubs of butter. And knowing the environmental context actually gives you a greater insight to that culture. And the last basic construct is a worldview, the way people tend to look at their environment. So next slide, please. Okay. Other cultural concepts. The first cultural concept that I'm going to touch on is cultural shock. I'm sure you guys have all heard of this, but this is literally when you're shocked by someone else's culture, and it could be something as simple as in some countries, women blend up and eat the placenta after they give birth, and that's shocking to some people. The next cultural concept is ethnocentrism. That's a person believing that their ethnicity or culture is more important or right than another. The next concept is multiculturalism, which is recognizing that there are many different cultures and subcultures in the world that need to be valued and understood. So there are similarities between cultures, but there are also subcultures within cultures. The theory of uniculturalism is that there's larger concepts and constructs that are innate in every culture. Cultural imposition is imposing your own beliefs on someone else. So it could be something as little as you touching someone and they're not comfortable. That could be a cultural imposition. Relativism is the position that cultures are unique and must be evaluated, judged, and helped according to their own particular values and standards. So you can't just say, one culture is this and another culture is that. You have to really learn and evaluate them each individually to know what they're all about. Cultural blindness is the inability to see any sort of recognize that your own lifestyle could be a cultural imposition to someone else, or being blind to someone else's culture, not knowing what they're going to need from their life. Cultural pain is any sort of suffering or distress caused by your cultural blindness. Being culturally bound is specific care, health, and illness and disease conditions that are particularly unique to a designated culture or geographical area. So in the Midwest, one thing that we do is tailgate Sundays, and not everyone does that, especially in Ann Arbor. We also have tailgate Saturdays where we spend all day with our friends, cooking out, eating, and then we watch a football game, which where you go over to the West Coast, there's not that sort of community focused around a football team. Queer diversity is variations among and between cultural groups from different lifeways. Stereotyping is classifying or identifying someone based solely on their culture or their ethnicity. Prejudice is stereotyping and when you put an action to it. So you're treating someone differently because they are from a different culture or ethnicity. And then discrimination is overt or covert actions aimed at limiting opportunity. So when prejudice is even more overt. So either you could be doing it without knowing it, or you can overtly be saying, like, you're black, I don't want you in my store. And then racism, I think everyone knows this term. It's any sort of discrimination based on a ascribed race. Maybe that's color of their skin or just a general ethnicity. So communication principles for transcultural nursing, there's verbal and nonverbal. So in every culture, there's different nonverbal cues that are used. In the Midwest, there's a huge thing about space, and if you stand too close to someone, they will automatically take a step back, versus if you're in somewhere like India or in Asia, they have much less personal space and boundaries. And then the super evident nonverbal communication is, I always say, is this: your arms crossed. It's very closed off, so the person doesn't feel welcome. Another nonverbal communication that is unique to the Muslim culture is that when women don't want to shake hands with a man from another culture, they put their hand over their heart, like the Pledge of Allegiance. So this is their nonverbal cue saying, like, listen, we're not going to shake hands. It's not okay with my culture. And so there's different barriers that can be associated with both verbal and nonverbal. But some of the verbal, most obvious ones are, of course, language. And another big aspect of this is interpreters. So what are you going to do in a healthcare setting if you don't speak that language? Obviously, different facilities use different things. At St. Joe's, we use the blue phone, but other people have people that are interpreters. Like, for example, my mother works at U of M, and she's an interpreter. And you have to be very careful when you're using interpreters, because they might not be educated in a culturally congruent way, so that even if they speak the same language, they might not be from the same culture. And you have to be careful, because sometimes the words of your patient might be filtered through the culture or the worldview of your interpreter. So the interpreters themselves have to be very educated in culturally congruent care and how to provide that. And then the biggest thing when it comes to communication from someone from another culture is respect. Just respecting other cultures and not judging them, I guess. And then another big thing that will aid in communication with a person from any other culture is using slang or jargon. So medical jargon, it all took us 4 years to learn all the medical jargon: hyperkalemia, hypokalemia, hyponatremia. So instead of saying something like that, saying, oh, you're hyponatremic, saying, oh, your sodium's a little low, sodium's an electrolyte, and just informing the person based on any sort of knowledge base, not assuming that they have knowledge, and trying to provide the most commonly used type of language so that they can associate with that. So to provide culturally congruent care, the first thing that you have to do is provide a cultural assessment. And the first step of a cultural assessment is doing a self-assessment, is looking at yourself and answering a set of questions that analyze your biases and your culture. We were actually asked to do this, and it's quite alarming to do, because you realize that sometimes the way you were brought up so much affects your culture. Like I say, I'm from Ann Arbor, so that says something about me. It says something about who I am as a person, but I was raised in private Catholic schools versus public schools, so that alternately changes my culture as well. That's another culture within a subculture. So there's Ann Arbor, and then there's a subculture of the Ann Arbor Catholic schools. The next step of a cultural assessment, is holding knowledge. So learning about these cultures and holding that knowledge and knowing what to do with it. And then after you know about the culture, then you can assess other people and do the cultural assessment based on that. And the way you can assess other people is the semi-structured inquiry guide, is where you have a list of questions based on that person's culture based on what you want to find out about their culture. And instead of going like, number 1, so where were you born? It's more of a discussion. You talk to the person, and it's more of a fluid kind of discussion versus a questionnaire, is how I like to describe it. So we're going to do a little mini self-assessment. So what is your culture? So we'll just do me because it's easiest. So race and ethnicity. I'm Mexican. My parents are from Mexico City, and I'm first generation. My religion, faith, and spirituality, I'm Catholic and a practicing Catholic. And then the next step is the values and belief system. So what do I value, and how do I look at the world through that belief system? So one of my big values and beliefs is judge not lest ye be judged. And that is how I approach every individual. And that is what I hold dear to me, and that's how I look at other people through that belief system. And then the next one is hobbies, interests, or activities. I'm a big athlete, so I always have to have sports in my life. I did sports all through my life, and I can't not be competing, and my boyfriend will tell you that is very true. And then the next part is where you were raised and where you live. So like I said, I was raised in Ann Arbor, even though I am first generation Mexican. And then your political and social views. So my political views are a little undecided at the time, but that does make up what your culture is. And the last step of your culture is any cultural stereotypes or ethnocentrisms that you have. Thankfully, I don't think I have too many ethnocentrisms. I've been exposed to many different cultures, so I've been fortunate enough not to develop any of those. And so, as you can see, we have the Sunrise Enabler, and it has this big scope, and as you can see, the overarching theme is the worldview, and then within that, there are 7 different branches of it that make up your culture. So that's everything from your education, your political and social views, technological factors, religious and philosophical beliefs, and all that goes in and influences how you view the world. And then externally is, how you present yourself to the world and what you do and say in your actions. So the other very important thing about providing culturally congruent care is knowing the difference between generic and professional care. So generic is another form of emic care. It's folk care or home remedies. The big thing right now is essential oils. So what do people do at home when they have a headache or they have a cold, that type of thing. Professional care, like I said before, is etic care, is the care that we provide, medical professionals. And you can see how it's very different. We have the home remedies versus, a surgical OR. And you can tell if someone's only used to receiving care from an emic perspective, they might be shocked to see people in masks and gloves when they're used to talking on someone one-to-one and someone giving them something specifically. So examples of emic care, I picked the most ridiculous examples, and they're cupping and coining. And as you can see, cupping and coining are both part of Chinese medicine, and if you're not aware of what they are, they can be extremely alarming. So a lot of times, kids would come into pediatrician's office, and the pediatrician's office is not providing culturally congruent care, and so they think it's child abuse. So cupping is where they take glass cups and put them on different places in your body to take out the excess wind, and the medicинist decides where to put them depending on what you need. And coining is pretty much rubbing a coin until you make a red mark to bring more blood flow to the area to help heal the area. So as you can see, if you saw these types of abrasions or lacerations on a patient, you'd be very alarmed by it. So having this sort of education is very important for healthcare providers if they are if they have patients giving themselves this emic care. So then, how do you decide how to provide culturally congruent care? Because obviously we can't accommodate every single thing that a person wants of their own health care. So the next step is the nursing care modes, decisions, and actions. So the modes of cultural care. So we have preservation and maintenance, accommodation or negotiation, and repatterning or restructuring. So preservation and maintenance is the main one that we should focus on, because whenever we can preserve a person's culture or emic sort of care, we should. For example, some women from a specific culture, when they give birth, they need to have a knife under their bed. So a way that my teacher actually described how she's done it is you take a little plastic knife and you just duct tape it under the bed. And so that way we are preserving that woman's culture. She's having an easier birth. She knows that she's being culturally cared for, and then so her whole birthing process will be better because of it. So accommodation negotiation is when you don't try to completely take away from what they're doing, but you refocus it on something that would be more beneficial. I already brought up the idea of the Ann Arbor tailgates on Saturday. So let's say you have a patient that is not an alcoholic, obviously, but drinks 12 beers every single Saturday in 4 hours, and obviously that's not good. So a very ridiculous example is to have them cut down from 12 beers to 4 beers during that 4-hour period, and that's a much more acceptable type of alcohol consumption. And then repatterning or restructuring is when they're doing something harmful to themselves, and we need to tell them that this is we can't have them do this, even though we would like to preserve their culture, because it's actually harming them. An example would be Bengali people chew on this specific root. The name escapes me, and they just chew it all the time. But it's very cardiovascularly active. So if they chew it excessively, they have lots of complications from it. So that would be an area where you have to be like, I know you really this is a part of your culture, but this is giving you cardiac symptoms, and we need to get rid of those. So you have to have them not chew that root. So and then the nursing actions, how do you balance this emic and etic care? And then you really have to be a patient advocate. You have to ask the patient first what their culture is, how they would like to be treated, and how they would like to be given culturally accommodated care. Because just because I'm Mexican doesn't mean I'm the same from another Mexican woman my age. We might have completely different views of what our culture is and what our culture means to us. And then, of course, you're a nurse, so you're a patient advocate, but even being more a patient advocate for this patient and for preserving their culture whenever possible. And then you have to focus on what people are doing well for themselves. So we discussed how, the placenta is one of the things that's quite alarming to people. It's not necessarily bad for them or not necessarily good for them, but we're going to preserve it if we can. And if she's doing something else that makes her better, like she runs every single day and that improves her cardiovascular health, we're going to tell her, after you're healed from being pregnant, you should get back to running every day, because that's something that is good for you, and we're going to try to preserve all the things that you're doing good for yourself. And unless what this study and what this branch of nursing has discovered is that unless it's absolutely detrimental to the patient, you should try to preserve their culture. So like I said, so if the Bengali person was chewing the root and wasn't having any cardiovascular symptoms from it, we would try to preserve that culture and allow him to chew that root. So how can we apply this to clinical practice? The first thing is communication, and as you know, communication with patients can be very difficult to start off with. So it can be even more difficult when you have someone from a different culture. So you have to be very aware of what you say and how you say it. So of course, we already talked about not using jargon or slang. The other thing is speaking slowly and clearly. If you've ever been to a foreign country and you vaguely know the language, when you hear people speaking it rapidly, you can't understand a word, but if they slow it down, you're able to pick up the meaning of the words. So same thing in English, we have to understand that Not everyone speaks English as fluently as we do, so we have to speak slowly and clearly, and that's one problem that I have myself. I'm a very quick talker, so I have to slow myself down whenever I have someone from a different culture or ethnicity, or even someone who's hard of hearing, an older client. You have to, very much slow down your speech and be like, "Hi, how are you doing today? I'm your nurse." This is, "Hi, how are you doing today? I'm your nurse." You couldn't even understand me when I said it that rapidly, and you guys are fluent English speakers. And then, of course, the other huge part of communication is the nonverbal communication. So always being open and, again, not doing the big crossed arms. And another thing that I kind of touched base on before is personal space. You should never impose yourself on another person's personal space. So maintaining a nice distance from a person until they say it's okay to approach them. And then another thing you have to listen to is your body language and the other person's body language. If you're coming into their personal space, they will show you that they're not okay with it. They'll close off, they'll move away. I gave the example that, we're from the Midwest, so we're used to lots of space and acres. And if someone from another culture, I've actually had standing in line at the grocery store, I've had an Asian person behind me, and she stepped right here close to me, and it was way too much, so I literally turned my body to just provide myself more space. And like I said, people will be very evident in their nonverbal communication if they're not happy with what you're doing. So how are you guys going to provide culturally congruent care? So I like to do do's and don'ts list. So introduce yourself, obviously. Always make sure that the person knows who you are. And ask the patient how they would like to be addressed. St. Joe's is great about this, as we have the preferred name on the board, but some hospitals don't do this. But if you called me by my middle name, I would never respond to you, and I would think you didn't know who I was, you didn't know why I was there, and honestly, all communication and any sort of care from that point would be shut off. And then the other thing is just be sincere. Don't be fake about it. Be respectful. Even if you have some sort of bias towards that person, you're still there to provide care for that patient, and you need to leave that bias at the door. And you might not like that patient because they punched you in the face earlier, but you still have to provide care to that patient and be sincere in your caring. You have to be altruistic in your manner. And then ask about specific religious needs and practices. Again, St. Joe's is really good about this because it's on the intake form when any patient is admitted. They ask about if they do, if they practice halal, or if they don't eat pork. So instead of just asking that through the assessment, you should ask that to each person each day, asking them, is there anything that we need to do religiously? Like at St. Joe's, it's a Catholic hospital, so they provide communion, and they provide different rites, like the rite of death, the last rites to patients, and that's very comforting for the family to know that they can receive that type of care there. And then acknowledge and reply to questions and concerns, even if you don't immediately know the answer. So I think we've all been faced with this, where someone's like, "Oh, what are my CT results?" And you didn't even know they had a CT. So the proper way to approach this is being like, "Oh, you had a CT today. Okay, I wasn't able to look at the results, but I will look at them right away." So you're acknowledging that person, you're answering their question, and you're telling them that you're going to get the answer for them. And then you actually have to go back and get the answer and tell them that answer. And then whenever you're faced with any sort of cultural issue, it's best to brainstorm. So ask your clinical nurse leader, ask your manager, is there anything we can do for this patient? Because when you have more people with more education, you're going to come up with better solutions. So the example that I gave of the woman who wanted to give birth and had a knife under her bed, they had to brainstorm to come up with how to keep it safe and not to make it a tripping hazard, not how to make it any other sort of issue, because can you imagine having a butcher knife under a patient's bed? Everyone would freak out about that. And then don'ts. First thing is, we talked about personal space and how you have to respect that, but another huge thing is touching. So don't touch a person without explaining or asking them if it's okay. So, ma'am, I'm going to have to touch you on your knee. You're here for a knee assessment, so I'm going to touch you. Is that okay? And you have to check and make sure that's with the patient. Most patients are very cool about it, but you do have to remember that you have to ask them first and explain why you're doing it. And don't be defensive, either verbally or non-verbally. We've all had instances where we were defensive against a patient and they could tell immediately, and then communication was shut off with that patient from then. So again, I come back to don't do the very typical cross your arms, which is very defensive nonverbal communication. Don't stereotype, discriminate, or judge. Don't be ethnocentric, and don't make assumptions. Just because someone is from a specific culture doesn't mean they believe exactly what you've met of someone else's culture that they have. Be ethnocentric, which is a huge problem in the U.S., I feel. We are a melting pot, and we have to accept people from all different types of cultures came into this country. Don't judge as very easily. You have to learn the person's culture before you can ask them any sort of questions and know where they're coming from. And discriminate and stereotype are kind of no-brainers. So, any questions?
I have a question.
Okay.
I recently had a patient that was a Muslim, and his preferred name was Baba, and then his first name. And I don't know exactly what that term means.
I don't quite know what that term means. I think it's like a term of endearment, I want to say. Or it could also mean, I think I've heard it mean like father or something like that. So that's something that we would have to, ask that patient, oh, what does that term mean to you? Because it could mean grandfather to someone. It could mean something completely different to him. That'd be something that would be a great opportunity for you to provide culturally congruent care and ask him how, by asking him how he would like to be addressed, you could open up the door and be like, oh, is there any other cultural needs that you have? So that's a great example where you could have provided culturally congruent care, and I know that you will next time.
So, as a nurse, you take care of patients, male and female, a lot of different cultures and stuff like that. What would you do in a situation where, let's say, only females are on the floor and the patient only wants a male to take care of him or her or to bathe him or her? How would you address that cultural friction that you might have?
So, again, you have to approach that patient and ask them pretty much why. And, of course, you have to do it in a very respectful way, because if you, sometimes when you start asking questions of people, they get very defensive. So what I would do if I was in that situation and there's no males on the floor, just be honest with that patient. Like I said, be sincere. Be like, listen, we really want to give you everything we can to provide excellent care to you, or remarkable care, which is St. Joe's motto. We want to be able to accommodate you, but right now we don't have any males on the floor. Is there a reason behind this? Is there a way that we could get you safely to do it yourself? If we kept you half covered, or maybe you let him, roll him into the bathroom, and have him do maybe just his private area himself. I've had even not even Muslim patients. I just had very
Conservative.
Yeah, very conservative white family, and they wouldn't let me bathe his son, and because his parts were his own. And that gets very sticky when you do any sort of bathing thing. So that's the perfect opportunity to ask them really what they need, and if there's